I have to thank Eric for this assignment. He gave me 5 bones to talk about, so there's not that many. I have no disclosures on the fact that he's already noted. I'm not a sports medicine doc. I take care of mostly high-energy injuries and chronic foot problems, and we're going to talk about 2 or 3 of the problems that we see associated with sports medicine type injuries and athletic trainers and primary care physicians might see on a routine basis today. The most common injuries we're going to talk about today are some midfoot stress fractures and some strains and sprains, and how we evaluate the midfoot injuries and what are the optimal treatments. There's a very marginal amount of level 1 evidence when we talk about treatment in these type of injuries. That much I'll tell you before we get into it. These are my goals for PowerPoint presentations. You got to be sincere, you got to be brief, and you got to be seated pretty quickly. So I'm going to be that. Now, out in the audience, I'd like to say, who likes to take care of midfoot injuries? Anybody out there? Probably not. And I think you all know why. Most of them don't get better as quickly as we want them to. They don't return to play nearly as fast as we want them to, and as nearly as fast as their parents or the athlete wants to return to play. So we'll just talk about that. A lot of understanding midfoot injuries is really understanding the anatomy of the midfoot. Obviously, you've just had a lecture on ankle bones, and we know what those 3 are. Right in the center here. Okay, Eric, this is not working. Pad is not working, Eric. Here it is. Okay, so the midfoot, we can see the 5 bones that we're talking about. The navicular and the first row, the navicular and the cuboid bone, and then the 3 cuneiform bones. They're kind of analogous to the wrist bones that we have, the proximal and distal carpal rows. They take a great deal of load. Here we're looking at them from the medial and lateral sides. You can see the cuboid bone on the lateral side is a fairly large bone at the articulation between the calcaneus and the 4th and 5th metatarsal heads at the TMT joint. On the medial side, the first cuneiform bone, also fairly large and not usually involved in chronic conditions. Understanding the type of injuries, the most important thing is understanding the ligamentous structure that holds the midfoot together. And I'm only showing you the plantar ligaments because the plantar ligaments are by far much more substantial than the dorsal ligaments and the small intertarsal ligaments. You can see the massive structure here, and it's multi-layered, interconnects all the major mid-tarsal bones. The lateral side, we can see also lateral ligaments there at the cuboid bone coming between the cuboid and lateral cuneiform, as well as the mid-tarsal ligaments between the mid-tarsal bones and the base of the metatarsals. We can also see transitioning along there the peroneal brevis and longus tendons, which we'll talk about a little bit briefly. One of probably the most important things about midfoot anatomy is the fact that our foot has a longitudinal transverse arch, and the top of the arch sits right at the cuneiform bone. And you can, just like a Roman arch, there's a keystone in there, which is the middle cuneiform bone. That bone takes tremendous pressure with weight bearing on each step and each push off. And if there's a disruption in those ligaments or the truss that holds it up, the arch collapses. And we can think of the best example of that is if you have a foot as a tripod, and if you have your 4 fingers down and your thumb down, and that collapses, something upsets that tripod, the foot falls over, and that creates long-term chronic problems for us. And that's why dealing with the midfoot injury is so important to keep that arch intact. Again, I'm showing you on the left, the mid-tarsal ligaments are very substantial. And on the right, the bony structure of the midfoot, and underneath of it, you're seeing the transverse arch. So everybody knows we have a longitudinal arch that needs to be supported with a shoe or a shoe or a selection or an insole, but most of us forget about the fact that it's transverse arch. You look down to this is the middle cuneiform bone. This is the top of the keystone of the arch, the transverse arch. You also see the trapezoid shape of that bone. And when that arch gets squeezed in the wrong direction, that bone can pop up out of place, become subluxar dislocated, and that's what we're talking about when we talk about Lisfranc injuries. We can't talk about the anatomy of the midfoot without momentarily talking about the tendons that cross the midfoot. Obviously, you've heard a little bit about different tendinopathies already this morning, and we'll only briefly touch on them because I'm restricted to midfoot, so we'll talk about the pathology that occurs in the tendons only through the midfoot. Here on the lateral side, two major tendons cross the midfoot, which are the peroneal brevis and longus tendons as they transverse from the distal aspect of the fibula, extending down to the base of the fifth metatarsal or underneath the midfoot to the first or medial cuneiform. Here on the lateral side, correction, on the medial side of the ankle, we have three major tendons. The one that gets the most trouble is your posterior tib tendon. Again, your most substantial tendon, just posterior to the fibula, coming down, and the posterior tib tendon inserts on the medial cuneiform and a little bit on the navicular bone. And you can see the broad insertion right in here of the navicular. And this little structure is kind of trying to point out an accessory navicular. A lot of people have them, and they're involved in the insertion of the posterior tib tendon, and they also can be involved in pathology as well. How do we evaluate midfoot? Most of the time we evaluate them with clinical exam and then plain x-rays. And everybody's seen an x-ray of the foot. But looking through the midfoot, we have the 5 bones right here. What we want to see is that the first metatarsal ray kind of lines up with the axis of the talus, and that does in this bone, in this direction. And then in the oblique view, which is over here on the right side, we kind of want to see the midfoot articulations between the metatarsals and the midtarsal bones, specifically here, the middle cuneiform bone. This is better known as the Lisfranc joint. We'll be talking about that in a bit. This is obviously an important articulation in the midfoot, and what we see in the line between is they're collinear. That joint is well reduced, and we're going to see a few x-rays in a minute that show it's no longer reduced. We're looking at a lateral view. This is an unstressed view. This is non-weight bearing, but you should see a collinear line between the axis of the talus, right along the blue line here, all the way down to the center of the first metatarsal head. When we see people having a collapsed arch, if you take an x-ray, you'll see a big change in that axis, and right about in the midplane, right in the midfoot, you'll see that the lines are no longer collinear, and there's basically an 150 degrees instead of collinear 180 degree line. Let's talk about the injuries to the midfoot. We'll talk about metatarsal sprains, tendon injuries, and inflammatory conditions, which often present as an injury, but actually they're really not. They're sort of these imitators that occur. Talk about fractures first. Navicular fractures, obviously one of the more important bones in the midfoot, takes a great deal of stress, and we see a number of different types of fractures with navicular fractures. The position of the fracture is often, if we have a medial fracture, that's often a avulsion fracture from avulsion of the posterior tib insertion. I don't know why this thing keeps jumping back on it. What we see in the mid zone of a navicular injury is often a stress fracture. We see injuries to the lateral side of the navicular bone. They're often very high energy injuries, the things I deal with, the motorcycle riders, things like that. So in avulsion fractures, you can see a good example right here in the red circle, and you can see the lucent line there. This is often associated with that avulsion, a midfoot twisting injury, pulls off the insertion. It's usually not displaced, and it takes a fairly long time to heal. Although they look like a minimal injury, this fracture can remain tender and interfere with performance for months on end, and occasionally they go on to non-unions. Most of the time we treat them just like it says in the slide here. We treat them with conservative approach, put them in a boot, put them on crutches, give them time to heal, and in most cases they do. Occasionally, we have to put a screw in it to encourage healing or do some other technique to get the bone to heal that goes on to non-union. Fortunately, they're fairly rare. In 30 years of doing this, I've probably only treated 1 or 2 of these that go on to non-unions. They're not all that uncommon, actually, in the general population that come into the office. I see probably 1 every couple of months. And a lot of times they're missed in urgent care facilities, not usually by the athletic trainers. They're usually sent in saying there's something wrong here, take an x-ray. This is some of the take-home messages today. We're talking about stress fractures. Every one of you has dealt with a stress fracture all over the foot and other parts of the body. I want to point out the one thing that I've seen different in the presentation of, and this is my own clinical assessment, the differential or the difference in presentation in a stress fracture navicular is they often come in with this sort of long history of, I got midfoot pain, doc. I've been running for months. I didn't change my workout like we often see. And you know, people that present with a metatarsal stress fracture, they'll tell you the date, time, and minute it happened. Oh, it happened on, on the second hill on the cross country, and the day later they were intensely swollen. These people keep on running, and eventually they show up, and you get an x-ray, and there's nothing really there. Now, the literature said, and I looked this up, 14 to 35% incidence of the stress fracture in the foot or navicular fractures. Clinically, I don't see this. It's probably closer to 5 to 10%. I see 1 or 2 a year. Now, obviously, some of my colleagues that treat the athletes in an acute setting, they probably see quite a bit more. When we see one, you got to put them in protective weight-bearing status. You have no choice. You got to take them out of their activity. They're not returning to. It's a tough discussion. They're not returning to athletics performance very quickly. I put them on crutches until they're mostly pain-free and they can weight bear in the cam boot. The other thing I see in the problem with cam boots and mid-fracture treatment is that cam boots, and all of you have used them, have an absolutely flat insole. But I just told you it's really important to support this arch of the midfoot, at least to take the pressure off and get the midfoot to heal and take the strain off the midfoot when people are walking on it. So I often tell them, or we often go in the little computer in the office setting, and I go to insole.com or one of those insole stores and get them a Spenco liner. You've all used Spenco liners, or even some of the semi-rigid liners, and put that liner in the boot. It makes them much more comfortable, and eventually they'll be able to weight bear. I don't know if it makes them heal any sooner, but it does make them more comfortable. There's no literature that says they heal sooner. Now, displaced fractures of stress fractures are not uncommon. They don't displace greatly. There's usually just a lucent line, and they often require a screw. I just finished telling you that they're often misdiagnosed or delayed in diagnosis, and the real reason is that there's no finding on the first set of x-rays. We don't see that lucent line until they've had the symptoms for several months. We used to send people for bone scans, but bone scans are kind of out of date. They're hard to get because not every radiology facility has it, and we often go to MRI, which is very, very sensitive to stress fractures in general. This MRI study on the right was a young lady that I saw just last week, actually in follow-up. She was a Division I mid-distance runner that was going to run only winter and spring. When she got to college, the coach says, "What you need to run cross-country because you got to be in shape." So she started running cross-country, and by the end of September, started having foot pain. She wanted to keep running, didn't tell anybody about it, and eventually she was limping, and by the middle of November, went to the on-site orthopedist who got an x-ray. It was absolutely negative for a stress fracture, although he clinically suspected a stress fracture navicular. So about 3 weeks later, when she came home for the Thanksgiving holiday, got the MRI, and you can see the lucent line right through the navicular. Now, we've been following her clinically. There's some evidence, but it's not real strong, that if you put a screw across that early on, you may be able to get them to heal a little bit faster, but there's not great clinical evidence, and she declined to do that. So I followed her clinically and got a follow-up MRI study, which I don't have here, now 5 months from the time of injury, and it's virtually healed, and there's no more edema in the bone. So we've let her start to train again to get ready for the fall season coming up. You can talk a little bit about midfoot fractures. Fortunately, you don't see too many of them on the playing field. These are usually the things that we see with the motorcyclists. People fall, great heights. They're high energy. Why are they high energy? Well, these bones are very compact bones. They're very strong. They take a great deal of stress, and they take a great deal of energy to disturb them. If you look at the x-ray on the right here, that doesn't look anything normal. And they call it sort of the midfoot jumble. There's multiple fractures there between on the cuboid bone, and half the joints look displaced. This is way out of line over here. The navicular is completely dislocated. This is the navicular bone. It's not supposed to be sitting here. This is typical of the motorcycle rider that we see. We deal with a couple of them a month around here. Fortunately, you don't have to deal with them very often on the playing field. When you have a serious midfoot fracture like this, their prognosis for returning to painless activity is guarded. We can rebuild the midfoot, we can put them back in place, we can put screws across the joints, and a lot of times they end up with post-traumatic arthritis and pain. And you all, as we said before, in order to dislocate or sublux these joints, it takes tremendous disruption of the soft tissues, and therefore you create a lot of scarring of the ligaments. In the x-ray you just saw, that the navicular is dislocated. Obviously that's a very bad omen. When we repair these midfoot, these people take a year to get better if they ever get pain-free again. They require arch support continuously and often are at no longer the same level they were before. We do try to treat them early on. If we find a minor midfoot fracture, we treat them just like any other fracture in the foot, non-weight bearing, mobilization. We don't use casts very often, like all of you use cam boots, allow them to do early range of motion if possible, but you still have to keep them non-weight bearing. Surgical intervention is usually open reduction, internal fixation. Just like we need an accurate anatomic reduction of these joints so that the joints line up again and you have the least chance of developing post-traumatic arthritis. In the stress fractures we talked about in the navicular, sometimes we can use a percutaneous screw, which is pretty minor surgery. When we talk about rebuilding the foot, the medial column of the foot, these part of the bones projected in red here, you have to reassemble them absolutely correctly. Same with the lateral column of the foot, and they need to be balanced again because the tripod gets disrupted and the foot pronates or supinates and doesn't do well. This is a motorcycle rider, saw it not too long ago. He just caught his foot coming off the bike. I mean, it's relatively low. He didn't go down the bike. It's relatively low injury, and you can see something wrong on the plain X-ray there. Geez, the navicular just doesn't look right on the plantar surface. And if you look at the CAT scan, the joint is completely disrupted. You can make a case for trying to rebuild this joint surgically, but there's only a few millimeters displacement, and most of the time we let them heal conservatively. Here's one that you guys will see a fair amount on the field and off the field, and that's a Lisfranc injury. I'm sure every one of you has seen Lisfranc sprains in the past. They're always usually higher energy twisting. They're often the lineman that has his foot plantar flexed, and then someone lands on the back of their calf, or someone stepping off a curb and misstepping because they don't see a curb. That's what happens in the general population. Braking in MVA, yeah, if you see it coming and your foot is slammed on the brake and you get a front end impact, we see Lisfranc dislocations. These are, again, higher energy things. For the low energy Lisfranc sprains, these joints are extremely tender and swollen. You have all seen them. They present with the same day of injury and they're not walking on it. You can move the metatarsal heads and they are painful. It is a clinical diagnosis, but we often get x-rays. Eric talked about grading these things and deciding whether we should or shouldn't get x-rays. I said, I'm leaving that out of the talk, Eric, because if they come to me as an orthopedist, I'm going to get an x-ray. And the x-ray for Lisfranc injury is the standard foot x-rays, and here's one. And we can see the joint, the second metatarsal joint disrupted. The collinear line is no longer lining up with the edge of the medial cuneiform and the edge of the second ray. A lot of times you can get an X-ray and it looks absolutely normal until we tell the patient to try to do a weight-bearing film. The plain film with it just sitting on the X-ray table with no pressure on it looks absolutely normal. You get an X-ray with a little bit of weight-bearing, and it's hard to convince someone when the foot hurts a lot to do that, but we do, and that's what you see. Well, in this case, this is actually more severe because you can see that there is a subluxation of the great first ray MT joint as well. We check the alignment of all these joints, and if it's malaligned, it needs to be reduced. This can't be reduced percutaneously with manipulation. When we see a displaced Lisfranc joint, it means open reduction internal fixation. So here you see on the right the screws that we placed to stabilize the first TMT joint. Second TMT joint, the Lisfranc joint, is now aligned, and the third joint, which was also unstable, is aligned. The problem with this is that if you're going to put someone back to play, ultimately, you got to take the screws out. Those screws are in there holding the bones reduced till the ligaments heal. That's all they're doing, just like the syndesmosis screw that KG was just talking about. And if you leave them in there, there's enough micromotion with the foot movement that they eventually will fracture the screws, and then they're a real nuisance to get out. Can't get them out because you only get half the screw out. You know, the non-displaced or undisplaced injuries, we still put them, I don't put them in a cast, I put them in a cam walker for 8 to 12 weeks so we can keep the hindfoot motion going, and the tibia-teres motion going. After they come out of the cam boot, you need to put them in a stiff-soled shoe to try to reduce the pressure of the midfoot with push-off. And that stiff-soled shoe needs to have an arch support in it. And after they transition out of the stiff-soled shoe, you got to have a shoe with arch support. What I often see in athletic shoes, particularly cleats, football cleats and soccer cleats, if you look in them, there's virtually no arch support in all of them. They're all flat on the inside. So those people probably have to get a shoe that will allow them to, a shoe that has enough depth or an insole that can be removed so they can put their own semi-custom or off-the-shelf insole in to protect it. Remember the little pearl, because it actually makes them feel a lot more comfortable. The cleats that we see are relatively poorly made, poorly cushioned. Now, we talked about some of the new diagnostic techniques for Lisfranc injuries. We are now using ultrasound. This is your first cuneiform, and this is your second metatarsal. And this little shadow, gray shadow, is the ligament, the dorsal ligaments between the two bones. And there's studies out there that show that the tension on this ligament changes with dislocation or subluxation. Unfortunately, I don't think that's a real good clinical measure of how serious the Lisfranc sprain is, because I just told you a few minutes ago that the more important ligaments are all plantar. So we would love to visualize those plantar ligaments with ultrasound, but it's a little hard to do. You can't use the probe dorsally because the sound waves don't penetrate the bone to the plantar surface. I don't think we figured out how to see them from the plantar side because it's very complex structures. So although people are working on it, and this is not a recent article, we don't use it clinically yet much. Eric found this study, and I thought it was really a neat study from the American Journal of Sports Medicine just from last year. It's a 10-year study in the NFL players that had Lisfranc injuries. Only 28 players. That was surprised that they rounded up. There are probably more of them. And 92% of them returned to competition 11.5 months later. And actually there was slightly more defensive players than offensive players. They actually did a very sophisticated study. They looked at their performance in tackles, yards gained, and everything, and they were virtually equal after you're out. But what it shows you is it takes a long time to get back from these type of injuries. 11.5 months meant back to play, and maybe if they injured themselves later in the season, they weren't returning to play until the next season. But it take a long time for these type of injuries to heal and get better. We can talk about tendinitis a little bit. I think you've talked a little bit this morning, but posterior tibial tendon crosses through the medial midfoot and inserts on the medial cuneiform and a little bit on the Vicker bone. And so chronic posterior tib tendinitis is not something that you guys have to worry about, but insertional tendinitis is, and you will see focal tendinitis right there. Sometimes you'll see some swelling in the tendon sheath, most of the time not, and it's often overuse problem, acute overuse, and we just put them in a cam boot. Again, solving a lot of problems in the foot is immobilization, reducing the impact loading, put them in a boot. And then they also take a little longer to get better. Tibant tendinitis, the same sort of thing. The tibant inserts over the navicular on the dorsal side of the navicular. They're acutely tender. I don't see very many of these. Probably the sports medicine people do. Sometimes physical therapy for stretching is good. Peroneal tendinitis on the lateral hindfoot, both the brevis and the longest cross the midfoot. And what you'll see is swelling, chronic swelling in the tendon sheath, people complaining. As long as they don't have a calcaneovalgus deformity, which is a hindfoot that's out of alignment, it's usually due to one of two things. The tendons are subluxating out of the groove that runs behind the fibula and creating irritation, or there's a tear in the tendon. And these tendons, the diagnosis is usually via MRI, and the tear is usually distal to the tip of the fibula. And they will get better and they'll do well if they're repaired. Other imitators of midfoot problems is gout, not probably common in your age group of people you treat, but it does happen. And I see it misdiagnosed often because everybody thinks gout occurs in the great toe, the MP joint of the great toe, and it does. But it occurs all over the foot. Why does gout occur in a foot? Because when you have high uric acid level, you need crystal to precipitate in a joint, and that's what gout is. Gout is an inflammation from these crystals. It's like putting sand in a ball bearing. That precipitation occurs in a joint that gets cold. So, our hips don't get cold, but our feet and our hands are exposed to the cold. You have a high uric acid level, you can get gout. And one of the joints that I see that's most often missed is the calcaneocuboid joint. On the lateral side of the midfoot, everybody comes in with a red joint, painful joint, and often the differential diagnosis is stress fracture. But when you look at the age group and you talk to the patient, this came on acutely. He wasn't doing anything. He was a couch potato. It's gout. Inflammatory arthritis is the other thing that we see. Psoriatic arthritis presents in the midfoot and forefoot. So if you have a youngster complain about pain in the toes and the midfoot, and there's some swelling but no history of injury, that's one of the things you can think about looking at his scalp, seeing there's psoriasis. One of the things we see. Take-home message. Most of these injuries are pretty obvious, but you can be aware of those occult injuries such as the navicular stress fracture. Lisfranc injuries are also very obvious, and we don't miss them very often. You treat things with mobilization. We rehab them just like you always have done, and if we see displaced fractures, displaced Lisfranc joint, it's early surgical intervention. And the take-home message for the patient is that these injuries take way longer to get better than they want. These are not ankle sprains. I thank you.